Shuttle. Hello everyone. A very good evening to everyone. I'm Dr. Divya Gupta, the original guru of Periodontics at DBMCI MDS. And today we are here to discuss the previous year's questions basically. So the main aim of this session is to recall certain topics and refresh your memory about the about certain questions and topics which have been previously asked. Basically, 1 month is left for your exam tentatively, and it is impossible for any of us to sit and listen to everything and read everything, right? Each subject. So basically, when we will be discussing these questions, you will have a rewind of most important topics which have been asked previously. So the questions which I have taken either are somewhat controversial. These questions are from previous years, previous 5 years papers, and they are somewhat controversial questions which I get doubts frequently about these questions in the Telegram group. So I have kept such questions. Apart from that, some other questions which I feel that okay, that needs a little bit understanding, those questions also I have kept. So with this thing, let us start the discussion. So the first question is, and this is a question which I think every day some other student is asking me this question. So basically, the question is, reverse architecture is most commonly seen in. Reverse architecture is most commonly seen in options. Option number A, trauma from occlusion. Option number B, aggressive periodontitis. Option number C, osseous craters. And option number D, food impaction. So guys, for this, you need to, I have told this many times. We have discussed this in doubt solving sessions also. We have discussed this in our live sessions, live classes, recorded classes, everywhere. The only way to remember this question is the most common periodontal disease is having reverse architecture is trauma from occlusion. Okay, then it is chronic periodontitis. Next is aggressive periodontitis, and after that is NUP. Okay, this is the order which you need to remember for TFO. I think some old edition, in some old edition, South Asian edition of Carranza, it has given NUP, necrotizing ulcerative periodontitis, as the periodontal disease having most commonly shows reverse architecture. But no guys, it is trauma from occlusion. Okay, after that, if in the option it is chronic periodontitis is given and TFO is not given, then it will be chronic periodontitis. Okay, so your answer will be in this order only. Okay, now the next question. This question is not controversial. This is a direct question which you need to memorize basically, and it was repeated last year in the NEET exam, and it was I think it was repeated in 2015 2014 as well. Okay, so the question here is mineralization of plaque intracellularly. Intracellularly means in the bacterial cells. Which of these organisms show intracellular mineralization, okay, inside the plaque? The options are option number A, Staphylococcus and Streptococcus. Option number B, diphtheroids, Prevotella and Bacterionema. Option number C, P. gingivitis and Prevotella intermedia. And option number D, P. gingivitis and AA. So here the answer to this question is, the answer to this question is this: diphtheroids, Prevotella and bacteremia. Option number B. Here the answer to this question is trauma from occlusion. And here the answer is diphtheria, prevotella. In question number 2, the answer is diphtheria, prevotella and bacteremia. Basically, these organisms show intracellular mineralization. All other organisms, Staphylococcus, P. gingivalis, AA, they show extracellular mineralization only. These organisms show intracellular as well as extracellular mineralization. Okay. Now the next question is question number 3. Coaggregation in dental plaque is explained by interaction between. Okay. So some of you might think that it is between gram positive and gram negative organisms. Now guys, this also we have discussed many times that in plaque, basically, which organisms are there? Whether it is green, whether it is purple complex, yellow complex, green complex, orange complex or red complex, all the 5 complexes in plaque, in the plaque biofilm has gram negative bacteria. There is no gram positive bacteria in dental plaque. It is gram negative bacteria which is there in dental plaque. Okay. So in Carranza it is written predominantly coaggregation occurs between gram negative bacteria. In Carranza it is written predominantly coaggregation occurs between gram negative bacteria. Now some of you might think why they have written predominantly if we are saying that all the complexes which are present in plaque have gram negative bacteria, right? Why it is not only gram negative bacteria? Because guys, it is impossible. There are 10 raised to the power of 11 bacteria in the oral cavity. In the oral cavity, there are both gram positive and gram negative bacteria, right? So it is impossible for anyone to specifically say कि no, gram positive bacteria are not there only. It is not like that. But yes, whatever studies, whatever researches have been conducted, it has been seen that it is most of the times what we get is the gram negative bacteria, and that's why there is predominance of gram negative bacteria in the plaque. All the 5 complexes which were described by Sukransky have gram negative bacteria only. Okay, so coaggregation. What is coaggregation? Coaggregation is a highly specific stereochemical interaction between the protein and carbohydrate molecules which are present onto the bacteria. What are these protein complexes or carbohydrate complexes? They are the receptors. Okay, so here just to refresh your memory about what coaggregation is. All of you have studied this. This is the tooth surface, right? This is the tooth surface. This is the tooth surface, and on this tooth surface, the first layer that is formed is of acquired pellicle, right? This is the acquired pellicle. Acquired pellicle is made of many proteins and carbohydrates, like polysaccharides are there, PRPs, histatins, statherins, all these are proteins which are there in the pellicle, and these molecules, they combine with this complex receptors. These are the receptors. Okay, both of them have complementary receptors, and these complementary receptors will combine. They will decide, okay, I will combine with this molecule, will come with only. Okay, it is predetermined. So these receptors are very specific for particular organism. That's why coaggregation is a highly specific stereochemical interaction between the bacterial surfaces. Okay, this is what is coaggregation, which you can see in this image. This we have studied in detail in our live classes also. So basically, coaggregation in dental plaque is explained by an interaction between option number A, gram-positive and gram-negative bacteria. Option number B, gram-negative bacteria mainly. Option number C, gram-positive bacteria and viruses. Option number D, gram-positive bacteria mainly. So here the answer to this question is gram-negative bacteria predominantly or mainly. Okay. Now the next question. Okay, so this image, I think it is, so just don't look at this image, guys. This is by mistake, it has been printed here. Don't look at this image. This is not at all related to this question. Okay, so now question number 4 is GCF secretion doesn't increase in which of the following cases? This is once again a question which comes many times in the Telegram group for doubts, right? GCF secretion does not increase, means it remains the same. In which of the following cases? Option number A is TFO, option number B is smoking, option number C is toothbrushing, and option number D is diabetes. Now remember, when GCF increases, GCF increases GCF increases in as inflammation increases. Okay, as the inflammation increases, the flow of GCF, gingival crevicular fluid, increases. What is GCF? GCF is this is another question which is asked. It is an inflammatory exudate. Okay, so GCF is an inflammatory exudate. So as the inflammation increases, the gingival crevicular fluid increases. Okay, so when we do toothbrushing, what we are doing? We are stimulating our gums. Okay, so what will happen? There will be increase in GCF volume. Similarly, in diabetes, we see that diabetic patients mostly will have periodontal problems. These patients will have more gingival inflammation. So in such patients also the GCF flow increases. Now there are two options which are left as TFO and smoking. It has been seen that what happens in smoking? In smoking, there is increase in inflammation. We all know that in smoking also there is increase in inflammation, but the sign and symptoms of inflammation are masked in smokers. In smoking also there is increase in inflammation, and the sign and symptoms are masked. It is masked in patients who are smokers. That's why what will happen? Initially, the patient will not have any periodontal problems, any gum related issues, right? But as the severity, what will happen beneath the connective tissue destruction, the bone destruction will keep on going, and the patient will come to us at a later stage when the tooth is mobile or when we cannot save the tooth, right? At that stage the patient will come to us and he'll say कि doctor साहब आज तक मुझे कुछ हुआ ही नहीं, not even a single blood came out of my gums. That is what is the drawback of smoking. Okay, so in smoking also what happens is it is seen that there is transient increase in GCF flow. There is in smokers there is transient rapid increase in GCF flow. But in TFO there is no change in the GCF flow. So the answer to this question is trauma from occlusion. Okay. Now the next question. Sub-antimicrobial dose of doxycycline SDD works by option number A, blocking interleukin-1, interleukin-6 and TNF-alpha. Option number B, activating MMPs. Option number C, suppressing bone growth, and option number D, collagen degradation. Now if such a question comes, most of us will be like, if we have not studied a very difficult chapter according to some students, which is host modulation, right? So we will feel यार अब कैसे, हमने तो सिर्फ ऊपर ऊपर से we just read it, ऐसे ऊपर ऊपर से हमने पढ़ लिया, अब हम क्या करें, right? So guys, see, if such a question comes, what you need to do is you have to do exclusion. You have to just know कि okay यार, हमने तो पढ़ा था SDD का function है to inhibit MMPs, right? We studied that. This is a direct line which we have studied. Okay, the main function of SDD is SDD SDD का main function is inhibition of MMPs, right? Now what is the function of MMPs? The function of MMPs is, the function of matrix metalloproteinases is to degrade collagen, right? And because of this degradation, what happens is connective tissue destruction plus bone resorption, right? Now here they have not given anything such as inhibition of MMPs, but what they have given, activating MMPs, and we know that SDD does not activate MMPs. SDD does not activate MMPs. It inhibits the MMPs. So this will not be the answer, right? This will not be the answer to our question. This is direct. Okay, ये तो हमको पता ही है. Now the third is suppressing bone growth. Okay, ये थोड़ा सा difficult option है. We'll see it afterwards. The fourth option is degradation of collagen. No. SDD, what it does, it is inhibiting the MMP, so it is helping in formation of more collagen. It is helping in formation of more collagen, right? Indirectly. So this question is also gone. This option is also gone. Now the third option, suppressing bone growth. SDD, what it is doing, it is helping in collagen formation, right? It is stimulating the fibroblasts, it is helping in collagen formation. Now during bone growth, there are two processes that are occurring. First, there is osteoid deposition. Now osteoid is what? It is organic matrix of the bone, and over that osteoid there will be mineralization, right? There will be mineralization over the osteoid. So that osteoid is made up of collagen, and that thus it indirectly SDD is helping in collagen formation. Indirectly SDD is helping in bone formation. Therefore it is suppressing the bone growth. No. Now what we are left with? We are left with only one option, and that is blocking interleukin 1 and interleukin 6 TNF alpha. Yes, this can be the answer, and this is the correct answer. Why? Because all these are what? Interleukin 6, interleukin 1 and TNF alpha. What are these? These are anti-inflammatory molecules. These are these are pro-inflammatory molecules, right? These are pro-inflammatory molecules, and these are responsible for inflammation. Thus, by inhibiting them, by inhibiting these cytokines, SDD is working, right? It is reducing the disruption of connective tissue and bone. That's why the correct answer here is A. I hope you understood the logic behind the answer A. Now, the next question, guys. This is just a picture to give you a brief idea of about how the host modulation therapy works. If see here, what happens is the bacteria attacks the host cells. The host cells produce prostaglandins, cytokines, and MMPs, which are responsible for inflammation, which are responsible for connective tissue breakdown and bone resorption, which further leads to pocket and clinical attachment loss, also tooth mobility and tooth loss. Now, in host modulation therapy or HMT, what we are doing, either we can give antimicrobials which will inhibit the bacteria, We can give NSAIDs and periostats which work on prostaglandins and cytokines. Periostat is SDD, right? A kind of SDD. It also acts on MMPs. Bisphosphonates periostat means SDD works on osteoclasts as well. Okay, so whole host modulation. If you don't want to read anything, just remember this diagram and you will be able to, you have to understand this diagram first, okay, and you will be able to answer all your questions related to HMT. Okay, now the next question, non-enzyme antibacterial component of saliva which inhibits bacterial colonization. Now here the keyword is non-enzymatic. There is enzymatic, there is proteinaceous components, right, in the saliva. Now enzymatic components are amylase, lysozyme, aminopeptidases. All these are enzymatic components which have antibacterial effect. The proteinaceous components are lactoferrin, histatins, statins, PRPs. All these are proteinaceous components which have antibacterial, antifungal and antiviral effects. Okay. So basically for this we have discussed the composition of saliva very nicely. If you want guys, saliva is very important. Every I think alternate years they are asking one question from saliva. So composition of saliva is very important. Just go back to your saliva chapter and just read the composition. Don't read anything else, but composition is very important. So the answer here is non-enzymatic. We know C. B is lysozyme, right? Lysozyme is, it is enzymatic. Amylase is enzymatic. Aminopeptidase is enzymatic. So the answer to this question is lactoferrin. Okay. Now the next question. This is also one of the questions which recently I have started getting a lot in Telegram group. And guys, please see this YouTube session and please don't ask. Every day we have to answer the same questions repeatedly to different students. It's better you see the sessions nicely, make notes of it, and then most of your doubts will be cleared, because the doubts which we are getting on a regular basis, we are solving it either in doubt solving sessions, either in discussions which we are having, or such rapid rewind sessions. So just go back to your sessions and listen them carefully. Okay, so now the 7th question is, when new periodontal fibers attach to new cementum. When new periodontal fibers attach to new cementum with new gingival attachment, the procedure is called option number A, reattachment, option number B, new attachment, option number C, repair, and option number D, none of the above. So here, if guys remember that new attachment and regeneration are the same thing. New attachment and regeneration are the same thing. They are not different. In new attachment and regeneration, we are forming new connective tissue, new bone, new PDL fibers. Okay, so that is what is new attachment. So new PDL fibers attached to new cementum with new gingival attachment is called as new attachment. The answer here is new attachment. What is reattachment? Now whenever we are elevating a flap, what happens is, see, I'll just explain it to you. This is the tooth surface, right? And this is the infection or the plaque calculus which is there onto the root surface, and this is the pocket, right? Now, when I have reflected this pocket, I am reflecting this reflection of flap. I have reflected this flap. So what will happen is, I have reflected this flap, right? So what will happen? Some amount of flap will be removed from here also, and here the tissue, the tooth was not diseased. Here the tissue was not diseased. It was disease free, right? It was disease free. So here the periodontal ligament fibers, the PDL fibers are viable. They are Viable, the cells are viable here. So what will happen? These viable PDL fibers from the connective tissue as well as from the bone as well as from the tooth, they will come in contact with each other and they will start reattaching themselves here. They will start reattaching themselves here at the apical region from where the flap has been elevated. That is what is called as reattachment. So I hope now what is reattachment is clear, and I know most of you know what is repair. Repair is healing by long junctional epithelium. That is what is repair. Okay, so the answer here is new attachment. Now the next question. Which is the factor you will consider when treating a case of pockets? Difficult question, right? You might think, "Arey, ye kya pucha hai?" Which is the factor you will consider when treating a case of pockets? So guys, remember, there can be pockets even in the absence of bone resorption, right? Sometimes the bone is healthy, but there can be initiation, start of periodontal disease. You will have pockets which are 4 mm, 5 mm, 6 mm, right? In such cases, it's not necessary that there will be bone resorption. So here specifically they are asking about treating a case of just pockets. They have mentioned nothing about bone. Okay. Now let us see the, always read your questions very carefully. Option number A. Option number A is accessibility to the furcation or defect. Option number B is GTR and new attachment. Option number C is new attachment and osseous regeneration, and option number D is new attachment and reattachment. So the factors which we will consider just for pocket, just for soft tissue is what? Accessibility to furcation and defect. When we are raising the flap, when I'm raising the flap, I need to think about what my accessibility will be to the bone and furcation defects, right? To the osseous defects. So this is definitely not the answer. Now the question number, option number B is GTR and new attachment. What is GTR? GTR is guided tissue regeneration. Here we are regenerating whole of connective tissue as well as bone, right? Bone graft is also a part of GTR. But here we are just talking about pockets, the soft tissue part, the pocket lining, right? So definitely this is not the answer. New attachment, osseous regeneration, I told you here also osseous is given. So this is not the answer. Definitely out of, by doing exclusion only we came to the answer. The answer to this question is new attachment and reattachment. What is new attachment and reattachment? I told you the concept of that in the previous question. Okay. Now the next question. Question number 9. Toothpaste component responsible for remineralization of tooth. Remineralization of tooth. Okay. Option number A, CPP ACP. What is CPP ACP? It is casein phosphopeptide. It is casein phosphopeptide amorphous calcium phosphate. This question can be asked in your pedo also. This can be included in your endo also. This can come in perio also. Okay. So casein phosphopeptide. Just a minute, guys. Okay, sorry. So casein phosphopeptide, it is what it is extracted from milk and milk products basically. And what does it do is it is incorporated into the toothpaste. So what does it do is it increases the level of calcium and phosphate, amorphous calcium and phosphate into the saliva, and thus this amorphous calcium phosphate is available to the enamel for remineralization. It can also be combined with fluoride, and thus there can be formation of fluoroapatite crystals. So in a paste in which there is combination of casein phosphopeptide, amorphous calcium phosphate and fluoride, what will happen? More fluoroapatite will form and it will be more resistant to caries. There will be more remineralization of the tooth structures. Okay, so toothpaste component responsible for remineralization of the tooth. Answer to this question is CPP ACP. Okay. Now the next question. Organisms associated with pregnancy gingivitis. Organisms associated with pregnancy gingivitis. Some of you think that, so I'll just read the options first. Option number A, P. gingivalis and Bacteroid melanogenicus. Option number B, Prevotella intermedia and Tannerella forsythia. Option number C, Prevotella intermedia and C, Campylobacter rectus. Option number D, Echinella corrodens and Campylobacter rectus. The confusion arises between these two, right? The confusion arises between option number A and option number B. So the order which you need to remember is Prevotella intermedia. Prevotella intermedia more should be given more preference than Bacteroid melanogenicus. Bacteroid melanogenicus, which should be given more preference than Tannerella forsythia. Then P. gingivalis. Okay, these can be like equal. Okay, P. gingivalis and Tannerella forsythia, but Prevotella intermedia should always come first, and after that only Bacteroid melanogenicus. So your first option to choose, the first option which you will choose is this, Prevotella intermedia and Tannerella forsythia. If in an option P. gingivalis, Prevotella intermedia is not given and P. gingivalis is given along with, Bacteroid melanogenicus is given along with any other bacteria such as Tannerella forsythia or P. gingivalis, then your second choice, the second choice will be option number A. Okay, so the first choice will be option number B, for second choice will be option number A. This order you need to remember to answer this question. Okay, now the 11th question, drug of choice for treatment of ANUG. Now it is not ANUG, it is just NUG. Okay, so the drug of choice for the treatment of NUG is, here students get confused between amoxicillin and metronidazole. Guys, it is not amoxicillin, it is metronidazole 600 milligrams BD for 5 days, or it can be metro 400 milligrams 3 times daily for 7 days. This will be your drug of choice for NUG. It is not amoxicillin. If in the options they have not given metro, then your second choice can be amoxicillin, but the drug of choice will always remain metronidazole for NUG. Okay. Now, another question. Now the next question is, which of the knives are used in gingivectomy? Which of the knives are used in just hold on. Which of the knives are used in gingivectomy? Option number A is Orban 1 and 2 and Kirkland. Option number B is Kirkland and Orban 3 and 4. Option number C is Merrifield and Orban 3 and 4. Option number D is Orban 1, 2 and Merrifield 3 and 4. So remember that for gingivectomy, Orban 1 and 2 and Kirkland knife 15 and 16. These numbers are used for gingivectomy. Okay, so here which knives are used for gingivectomy? Orban 1 and 2. So here, and Kirkland, for Kirkland they have not given any number. Here they have given Kirkland and Orban 3 and 4. Orban 3 and 4 is not used. Orban 1 and 2 is used for gingivectomy. So the answer to this question is Orban 1 and 2 and Kirkland 15 and 16. Okay, remember this number. Now don't get confused. Even if it is given wrong somewhere, I have searched it in many books and then I am telling you that these are the numbers which you need to remember for gingivectomy knives. Now question number 13. As compared to early plaque of non-calculus formers, early plaque of heavy calculus formers has option number A, less calcium, option number B, less potassium, option number C, less phosphorus, and option number D, no change. For this also I have told you many times what order, what thing you just need to remember one single line. You can, these are just facts which you need to remember, and these, if you remember, will get you full marks, right? They'll get you full marks in your MCQs. So you have to remember that compared to early plaque of non-calculus former, early plaque of heavy calculus former has 3 times more phosphorus. It has 3 times more phosphorus. It has more calcium. It has more calcium, and it has less potassium. So remember that for class calculus formation, phosphorus is more important than potassium. So here the answer to this question will be option number B, less potassium. Okay. Now the next question. Another question, a very easy question, but still students make mistake in this, and that mistake is because of one simple, we don't pay attention to one simple word here. So remember, see here, question number 14 is patient with furcation involvement, questionable patient cooperation with a complicated prosthesis. So the patient cooperation is not good, furcation involvement is there, it has the patient has complicated prosthesis. What is the time of recall in the first year? So remember guys that Merin's classification, this also I have told many times, Merin's has divided the recall into recall of first year and after first year. In after first year, there are class A, B and C. So in the first year, in the question, they have clearly asked the first year of his treatment. What will be the recall interval? So in first year, it is very easy to remember. Either it will be 3 months. If the patient has undergone routine therapy, that is not a very complicated case, then it will be 3 months. You have to recall the patient at 3 months. But if it is a complicated case, the patient has undergone multiple dental treatments, you have to recall that patient at 1 to 2 months. And for class A, B and C, means after 1 year. After 1 year, you have seen the patient, you know how much the patient is motivated to maintain the oral hygiene, how good the patient is at maintaining the oral hygiene, right? What problems have not arrived till now in 1 year. Accordingly, you can classify the patient, whether the patient has any systemic disease or not. Accordingly, you can classify as patient as class A, B and C, and then you can decide whether to recall the patient at 6 months to 1 year, 3 to 4 months and 1 to 3 months. Now here you don't need to remember everything. Just remember that the patient maintains excellent results in the first year, right? The patient maintains excellent results in the first year. Recall the patient at 6 months to 1 year. Good results. The patient has some systemic disease, but still the pockets are good. It is not means it is not increasing, the bone loss is not increasing, the patient is maintaining a good hygiene. Recall the patient at 3 to 4 months. But if you feel that the patient needs to be motivated and has uncontrolled diseases, then you need to recall the patient at 1 to 3 months. Okay, so the answer to this question, first you recall a patient with difficult prosthesis and everything. The answer to this question is option number C, 1 to 2 months. So just pay attention to few words, and these are the questions you can never go wrong, right? Now the next question. Another question which I frequently get. Junctional epithelium is option number A, completely permeable, option number B, semi-permeable, option number C, non-permeable, and option number D, none of the above. Now in Carranza, they have said that junctional epithelium is permeable. Junctional epithelium is permeable. But here, permeable does not mean it is completely permeable. It will allow all the bacteria or certain large molecules to pass through it. No, guys. It is a semi-permeable membrane. It is not completely permeable. It is a semi-permeable membrane. It allows passage of certain substances only. It will not allow passage of bacteria. It will not allow passage of certain molecules which are larger than 100 kilodaltons. No, it will not allow, right? So, it is a semi-permeable membrane. The answer to this question is a semi-permeable membrane. Now, the next question. Laser used only for soft tissue surgeries. Laser used only for soft tissue surgeries. Only for soft tissue surgeries. Now, lasers, more importantly, the lasers which we study. I'll write it here. Lasers, they can be diode lasers. They can be Nd:YAG lasers. There can be erbium YAG. There can be erbium, chromium, YSGG, and lastly carbon dioxide lasers. Now I'll not go into the detail of this because we have studied this in detail in our classes, right? But remember that diode and Nd:YAG both are soft tissue lasers. Soft tissue procedures can be done with them, and more commonly diode lasers is used, more commonly used. Okay. Other three, erbium YAG, erbium, chromium, YSG, and carbon dioxide are hard plus soft tissue lasers. But carbon dioxide laser is very expensive, not used that much. In this category, erbium YAG or erbium chromium YSG, whichever option you are getting, between these two, you will get only one option. So any of these can be used more commonly if both the options are given. Erbium YAG and erbium chromium YSGG is given. Then you have to choose this erbium YAG, more commonly used. Okay, because one more molecule is added here, it is more expensive than erbium YAG. Okay. So the answer to this question will be diode laser. Don't ask me Nd:YAG is a hard tissue laser. No, Nd:YAG is not a hard tissue laser. It is a soft tissue laser but less commonly used because it is more expensive and we have a cheaper option available, right? Now, question number 17. After periodontal flap surgery, patient is recalled in how many days? So it is not 1 month, it is not 2 months, it is 1 week. After periodontal flap surgery, patient is recalled in 1 week. Patient is recalled in 1 week to check how the healing is progressing, to check how the patient is maintaining the oral hygiene. Okay, so the maintenance after phase 1 therapy, it is very important to go to maintenance phase, phase 4. After any surgery, it is very important to get phase 4, means follow up. Maintenance phase is very important. So after every phase of treatment plan, we go to phase 4. Remember this. So we have to recall the patient at 1 week after periodontal flap surgery. Option number 18. Question number 18. Aggressive periodontitis differs from chronic periodontitis as the former has. In this also, students get confused between wider bone loss or narrower bone loss. Remember guys that aggressive periodontitis, okay, aggressive periodontitis has a wider bone loss. It has an arc-shaped bone loss, right? It has an arc-shaped bone loss and it is wider than that in chronic periodontitis. So the answer to this question, it has a wider bone loss. Now, question number 19. All of the following can be included in active tissue engineering purpose. What is this active tissue engineering in periodontal procedures? Except, now here one more thing is except. Now you need to know that tissue engineering, this is something new. Tissue engineering can be divided into active and passive. Now in active components, all the molecules which by themselves take part in the bone formation and tissue formation, such as biomolecules, such as BMPs, their platelet derived growth factors, all the molecules of PRF, they actively take part. Bone graft osteoinductive molecules, those take part in bone formation. Those molecules help in regeneration of the tissue, so they are a part of active tissue engineering concept. Now some molecules, they are passive components. They don't take part in they just act as a scaffold over which the healing can progress, but they will not by themselves help in healing, such as conductive bone grafts, or there are certain membranes which will just help as a scaffold, and they will not have any components which will help in bone healing or tissue healing. That is what is passive tissue engineering concept. Now let us see the options. Option number A is bone morphogenetic protein. Option number B is autologous fibroblast. Option number C is biological dermal acellular graft, and option number D is none of the above. Now option number A is bone morphogenetic protein, and we know that BMPs help actively in bone formation and tissue formation, right? Connective tissue formation. So it is negated. It is not the answer. Option number B is autologous fibroblast. Fibroblast, autologous means my own fibroblasts are used and they are very active. They will help in collagen production. So definitely B can be the answer. B is not the answer because they have asked the except. They have asked except. Option number C is biological dermal acellular graft. Now here they have extracted a graft from some animal or human source, but they have deprived it of cells. Acellular, the key word here is acellular. They have deprived it of cells, means it does not have any living component in it. It's just a fascia sort of thing. It does not have any living cells, and if no living cells are there, it will not help in healing, right? It will not help in healing. So the answer here is option number C, biological dermal acellular graft. Okay guys, so with this we have completed this session. I hope some of your doubts are cleared after this session, and if you still feel that you have doubt in any of these questions, guys, let me know in the comment section, and all the best for your exams. Just stay focused and try solving as many questions as possible from past years, guys. So thank you so much and all the best.